welcome back to our pre-conference workshop series here at EACD and IAACD 2025. We are currently set in the monastery itself in Melbourne. What a wonderful setting to be talking to our dear friend of the podcast, Dr. Wade Shrader from Nemours. Hello and welcome.
Thanks, Dana. Thanks so much for having me back on the podcast.
Oh, it's such a pleasure. I would say that as from a family perspective, it's so wonderful to speak with you. We had Carol on last time as well. And Ginny tells me I need to make sure I speak to pretty much everyone in your family. So we will definitely make that happen.
Sounds good.
But when I looked at this particular conference and I saw that what you'll be talking about, and you're part of quite a number of things for this whole conference series, you do have a keynote which is titled What is in the long-term perspective. And I thought, let's go into some of your keynote.
Yeah.
But it sounds like you give us a little bit of a history lesson as well, which is so important. Particularly, I mean, look at where we are. This is 1,000 years old. Let's go into it, because I think our future is often based on the foundations that have been laid before.
That's right. And we should learn from the past.
We really
should, right?
Otherwise,
we keep doing that
That's
sometimes, right?
Yeah.
So they particularly the scientific committee and the chairs of the conference asked us to focus. It's me and Tom Dreyer. We're partnering together, the orthopedics for the orthopedics keynote, where we're going to look at the past, the present, and the future of orthopedic care of children with CP. So really, really excited to pull all that together. I'm doing the past and the future, and Tom's doing the present.
I love that.
So really talking about standards of care. And so, we go into a little bit of the history of how cerebral palsy was first described and how it was popularized.
And when was that? I mean, you've done all the work for us. So
so I won't ever, no one will come to my talk then. So Little was the first person that described it, right? Who talked about Little's disease and talked about it and described it actually pretty accurately. So it's been around for quite a long time.
Very long time. And do not worry, this will be keynote speakers, when they come into the podcast, everyone comes back and listens to this many times, and we're not going to release this till after. So you've got to come. You told me that. You got to come.
Absolutely. So we talk about that. We talk a little bit about some of the early surgical treatments. I talk about the formation of the American Academy of, back then, the American Academy of Cerebral Palsy, which is now AACPDM, which was really one of the founding members of IAACD. I'm the past president. So we talk about that history. That was in a lot of ways models for all of our scientific organizations going forward. I talk about a lot of the mistakes that we made surgically. We extrapolated some polio treatment.
Tell me about that. I had no idea about that.
Yeah, so a lot of the, we see kids with CP that have weakness, motor weakness, and have difficulty. They have some spasticity. Sometimes kids with polio would have spasticity. And so there were some tendon lengthenings and tendon transfers that were used to treat kids with polio.
Right.
The problem is that kids with polio have normal selective motor control. Right? And so when we tried to transfer that knowledge and extrapolate that over to CP, it didn't work so well. So we had to kind of change gears and change our approach a little bit. So I talk about that through there, so it's kind of fun.
That's really cool.
Talked a little bit about how we did research back then, which if you read literature in CP, or especially surgical literature, even from the 1980s and 90s, it was small little series, only focused on the x-rays, and everything did pretty well, right? And so there wasn't any of this family-centered care or patient-reported outcomes, none of that stuff, no multi-center trials. So
it's come a long way.
It has come along in a relative short period of time. So, I mean, again, like I said, you look at the literature even from the 1980s and 90s. So, and then Thomas will pick up and talk about kind of the standard of care currently. SEMLs, multi-level surgery, rehabilitation, all of that together for that. And he has some interesting points that might be a little spicy, which is pretty good.
We always like a bit of spicy.
A little bit of spice, that's pretty good. And then I kind of talk a little bit about the future, talking about, early identification and how genetics might intersect with surgical care for preventative surgery.
What are your thoughts on that? What are you thinking how that intersects? Because that's been a big topic in the theme lately, is genetics. And because there's a lot unknown, but we all kind of feel that there is something there. Technology's catching up. And,
absolutely.
Yeah.
I think genetics is an incredibly important adjunct to our diagnoses. I think it's going to be growing. I think it's growing and changing exponentially every 3 years or so. So we're part of the genetics consortium and looking at some of those you know, some of those outcomes. I just got one of our papers just got accepted. Michael Kruger just contacted me,
Yes, wonderful.
which was great. I just got an
Great.
email from him overnight.
Yeah.
So, you know, so I'm a big fan of that. I think from a family's perspective, it's incredibly important. And then I think it's important for us to do two things, right? It's important for us to go down that road where we're looking at, you know, maybe, you know, unique drug trials, looking at unique genetic issues and trying to determine other mechanistic forms of what's going on for us from a pathophysiology perspective. But it's also important for us to take a step back and really extrapolate things like hip surveillance
Yes.
to this broader thing. I've already found some families that somehow get an early genetic diagnosis and say, well, I don't have cerebral palsy.
Yes.
And therefore the providers will say, okay, well, we're not going to have to do hip surveillance for them, and that's the wrong thing,
I'm so
right?
glad you mentioned that, because there have been increasingly, I think, a lot of clinicians' caseloads. It's not just cerebral palsy, it's
Yeah.
much broader.
Yeah.
And every now and then you catch yourself and you go, have you had your hips reviewed?
Right.
Well, like, you know, because CP, it's a given, and they are straight through. The
Especially in
pathways are
Australia,
clear.
right?
Yeah,
In Australia, they have a
Yep.
CP diagnosis, they're going to get hip
The
x-rays.
pathway is clear, yeah. And so every now and then we do have to catch ourselves and go, oh, where do you go? Have you got it? And most of the time, every now and then we catch children who are 5, non-ambulant, and they go, hip surveillance.
Right. Exactly.
So it comes down to clinical care pathways, which is something I know you're very passionate about, isn't it?
Yeah. So, and again, I think you can't be dogmatic about it. We know that the tone disorder doesn't really correlate with hip dysplasia.
Yeah.
The hypotonic kids can get hip dysplasia just like our spastic kids.
Yeah.
So it's really about motor development.
Right.
So it's really, that's the message.
Yeah.
If you've got a kid that's got significant motor delays, we need to be doing hip surveillance.
Yes, yes.
Right?
Yep.
And that kind of gets into the early identification and genetics.
Yep.
You can identify that and hopefully extrapolate that even further. And so that can better
Brilliant.
inform things like surgical care.
Sure.
Other things in the future, machine learning and how we predict certain gait outcomes, I think is really right on the cusp of already there. Smart orthoses, wearables,
What
we're
are
doing
smart
that.
orthoses? Tell me about smart orthoses.
Well, there's already smart prosthetics. You look at sort of that. So what about, why
Sure,
can't we do that for an orthotic, right?
Sure.
Where the kid, maybe it's a solid when they need it for ambulation, but then they can go and they know.
That's always been the dream,
Isn't
hasn't
that
it?
right? And
Yeah.
it can be flexible when you're going up and down stairs, all
That's
kinds
right,
of different
yeah,
things,
rather
right?
than change the pair or find
Yeah.
funding for that.
Right.
Yes.
And we do
That's a
that,
great one.
prosthetics, we do that
True,
already.
yeah.
It knows when you're walking, it knows when you're running. The smart knee changes for that.
Uh-huh.
So,
exciting.
so that's some exciting things about that. I think the wearables are a really big deal. I'm wearing my watch now.
Yep.
We're doing our step counts.
Yep.
We do a lot of research on step counts
Yep.
and walking activity in the community as an outcome from surgery.
Brilliant.
And so I think that's just going to become more and more prevalent.
Brilliant.
So.
And what are your thoughts are, you sort of mentioned it a little bit before and it got me thinking, in terms of, you said, hypertonic versus hypertonic, and we know that hips, because that was an old thought perhaps, wasn't it? The frog leg position, you're not less likely to...
You use your physical exam to screen, oh,
Yeah.
he's tight in adduction, we need to get hip x-rays,
Yeah.
but that's not
What do you think is,
Not
there's
that
been a lot
accurate.
of theories coming out lately about what we think is contributing to why hips are the way they are, regardless of whether they're spasticity or hypertonia. What are your thoughts on that from what you've seen?
Yeah, I mean, I think, the studies from Australia have been really profound, right? And the studies from Scandinavia have shown the same thing. I think it's all related to their motor trajectory and early growth and early motor trajectory.
Sure.
Our hips are made to grow into maturity, into a more mature space with walking at 12 to 18 months and running and being normal toddler, having more normal loading on those hips
Right.
early on.
Yeah.
And when you don't have that, then some of those more primitive growth strategies happen to the hip. And that's where we end up with pathological responses to that. And the bone as a living tissue responds to those loads.
Yeah.
And so, I think that's why we see it in hypotonic disorders and we see it in spastic disorders, is because for that group of children, their motor disability in terms of what they're not doing
Sure.
is pretty similar.
Yeah. And it ties in so beautifully in the sense that you're right. We're talking a lot about early intervention. We're talking like what is early,
Right.
and so we're
Earlier
probably
and
a bit
earlier,
earlier
right?
and earlier.
Right.
That's right. And are we intervening a little bit late? We probably are. We're waiting too long to see whether skills develop and they have a diagnosis. It's not going to develop on its own. We need to think about what early means
Yeah.
and how that relates to hips. I think from a therapeutic perspective, that has definitely changed the course of my thinking in terms of what early means. For you, as an orthopedic surgeon, what has happened in the last little while, I'm
Yeah.
talking last few years, that you think has been the most profound shift or change in the way that things have been approached?
Well, surgery tends to be a slow-moving discipline, which is good in a lot of ways. You don't want somebody being rapidly going down some road before it's proven.
That's right.
And so it's very, incremental in how we've grown over time.
Yeah.
I would say probably the idea of guided growth around the hip is probably the thing that would make that qualification the most. And I still say that with a bit of qualifications because I still think it's pretty early. Some of the initial series that came out were in some older kids, which it probably was not as effective because again, I talked about that growth all happens really, really early. 18 to 48 months is really when those hips develop the most.
Right.
So we have a guided growth series that we're presenting. I think it just got accepted for publication, which shows some modest results, better when we do it in the younger kids.
Okay.
And even when our results were a little more modest, it seems to delay the progression of hip dysplasia, which would be important. So if you had a kid who had really significant dysplasia at age 4, traditionally we might go ahead and do a bony reconstruction for them.
Yep.
And then they're at higher risk for a recurrence, and they might have to have it again when they're 10, 12.
Yeah.
If we can delay that initial surgery up until they're 8 or 9, maybe their risk of recurrence would go down. And so we're really starting to look at all this. We've been doing it for several years and just now starting to report our results.
That's
so it's
fantastic.
encouraging.
Yeah.
It's hopeful.
Yeah.
It's not a solution completely, but
surgery's on the minds of many parents,
It
isn't
is.
it? And it's the when will it happen and can I prevent it?
Right.
And then it happens and did I do enough? There is a lot that centers around surgery. For parents who are navigating through that space, and they're thinking, when might it happen? And is it because of me not having done enough? What's your message for those parents?
the guilt. I mean, they feel that guilt.
Yeah,
And I tell
very
them,
real.
you could have, there's no amount of therapy, and there's no amount of other things you could have done to probably prevent that from happening.
Yeah.
It's just, it's a matter of, the degree of your child's disability that you had no control over, right? And we're going to do this surgery in large part. Our hip surgeries are preventative surgeries. We're preventing them from becoming have significant problems with pain and worse disability from that. So, I think that approach, I think, is a really healthy approach, and families are able to do that. Similarly for scoliosis. I get families all the time saying, there's got to be something we can do to prevent this.
Yeah.
And I go, I wish we could.
Yeah.
But
Because the spinal brace option is a tough option. It's tough.
well, that's a tough
really
option,
tough, isn't it?
and the bracing options in the literature have shown not to change the course really for neuromuscular scoliosis.
Yeah.
So that's a really hard pill for families to, right? Because they're like, okay, well, I have friends that their children have idiopathic scoliosis, and those braces work there, but they don't seem to work when it's kind of neurologically mediated.
Yeah. The last thing I want to touch on is what we spoke about last time, is whether there's been anything updated from an SPML perspective. Has there been any changes?
So when I talked about SPICE there, so Tom's going to talk a little bit about SPML there.
I was wondering whether that was a
we are so that was last year. I have that same talk here this year where I'm talking about the consensus group that looked at SPML, some of which do some PERT procedures and all, and it was a pretty clear consensus was that, in ambulatories, percutaneous heel cord surgeries are not, in ambulatory kids, it's not a good idea. Like increases risk of crouch. I think the big message from that group is that we look at the level of evidence in the literature, and there's just not much out there on SPML, right? And in general, we make some comments that, surgical decision making and how we educate our families shouldn't be driven by like things on social media necessarily from us. Shouldn't be marketing from physicians and all.
Yeah.
And that it should be based in science. And
right.
and if if we have a procedure that we really think is better to help children and their families, we should try to help the broader community
Yeah.
understand that and all. And that there's a big need for that type of evidence for SPML.
Yeah.
We're in the process of submitting that paper for publication
Oh,
right
are you
now.
now? Okay,
Yeah.
fantastic.
So yeah, and so so
Yeah.
I think it's I think it is continues to be an ongoing issue. I would love to see some comparative effectiveness research that looked at SPMLs versus some of our contemporary surgical techniques and
Wonderful.
surgical
Yeah.
and postoperative pain management, because in most of our minds we don't think that is, that those are, that SPML would be better than that. I mean, but
Which is often, that's how it's marketed.
that's
that it
often
is
how it's presented to families,
fast
right?
recovery.
It's bigger recovery. It's just as good as the other surgery.
That's right.
And it's more minimally invasive and less painful.
but
And
clearly
so,
unfounded.
well, there's
in
just
a
nothing
lot of
there's nothing
aspects.
currently in the
Yeah.
evidence right now
Yeah.
that would suggest any of that. So
Yeah.
I would love to see some head-to-head studies about it.
Fantastic.
Yeah, and that would be fantastic. I think that would help a lot of families,
I
right?
think it really
And
would.
and
It really
and for
would.
those of us
Yep.
who really want to, most of us want to do really good by our patients.
That's right,
Right?
yeah.
If
That's why we're
was
here.
if that was the best
Yep.
way to do it, then
Yep.
we'd all change
Absolutely.
our approaches. Right?
Absolutely, yeah. We've got to do the work. We've got to do the science.
do the work to show it,
to
right,
be able to show
absolutely.
it. Yeah.
Absolutely.
Wade, always lovely to speak with
great
you.
talking to you, Dana.
I love your passion, and I was traveling through. I was in Malaysia not too long ago, and I had a family who really wanted to follow your work, and they have a child. They travel about a little bit, and they look to places like Nemours. Like there is this confidence because it is grounded in science as much as we can, but always with the person and the family in the center of it all. And I think that's the message that you get out there so well.
Well, thank
So
you.
thank you.
Thank you, Dana.
Thank you for your contributions to this amazing conference. For everyone who's been listening, another great episode, of course, here with Wade. So much more to come, though. And so just stay tuned for more episodes, and we'll talk to you all again really soon. Bye.